Okay, can.
Okay, Dr. Kumar and Dr. Lee, we shall start now. Is that all right?
Yeah, sure.
Sure. All right, great.
Yep, sure.
Okay. Very good evening to everyone in attendance. Welcome to our respiratory medicine webinar for the month of February. This is our fourth and final week for the respiratory medicine webinar. With us today, we have got our speaker, Dr. Lee Chiao Peng, and also our chairperson, Dr. Kumarish Raj from Hospital Raja Permaisuri Bainun Ipoh. Dr. Kumarish, our chairperson for today, graduated from University of Malaya in the year 2004, subsequently obtained his membership of the Royal College of Physicians in 2010. He then completed his respiratory medicine fellowship in the year 2016, and subsequently is currently based at Hospital Raja Permaisuri Bainun Ipoh as a consultant pulmonologist. His areas of special interest are in pulmonary physiology testing. And with that, Dr. Kumarish, the floor is yours.
Thanks, Ko, and also thanks to the college for this opportunity. So we have quite an interesting topic today, pulmonary hypertension, which is actually a very complex topic if you delve into it. But we are fortunate to have Dr. Lee Chiao Peng from Serdang Hospital today to make it easy for us. Dr. Lee is a consultant pulmonologist based in Serdang, I think, since 2021. He got his membership in 2015 and that completed his respiratory training in Malaysia and Australia. He had special training in severe asthma on biologics as well as pulmonary arterial hypertension. So without further ado, and in my opinion, Dr. Lee is the best among peers to make pulmonary hypertension easy for us. Dr. Lee, the floor is yours.
Hi. Can you hear me?
Yes.
I'm so sorry. Yeah, I think I lost for a while the internet connection, but I think we are fine now. Sorry, I just switched it. Okay, very sorry. And thank you so much for the very kind introduction, Dr. Kumarish. I'm also thank this College of Physicians for inviting me to give this talk. I think this is a very good opportunity for me to introduce this disease to to the College of Physicians and the people who are actually interested in this disease. So let me just share my screen first. All right. Can everyone see my screen?
Yes.
Yes.
Okay. Okay. Wonderful. Let me just close this up. Okay. Okay. So hi, everyone. Very good afternoon, and thank you for joining me today. So my topic was given to me is pulmonary hypertension made easy. I'm trying my very best to tell you what this is. As what Dr. Kumarish mentioned, is not a common disease that you will find, but however, it is a very important topic that we should be aware of. Okay, let me just go ahead. So this is my disclosure. I received some funds and fees from different companies, but as for this talk, I have nothing to disclose. And the objective for my talk today is obviously what pulmonary hypertension is. So I will try and make it simple. So nothing hi-fi in this talk. So I'm just going to give you some idea of what pulmonary hypertension is, and then how do I investigate and how you can help in finding this group of patients, and what are the this classification based on the latest guideline, which just came out just last year. I think everyone who are treating pulmonary hypertension was very thrilled and happy to see that finally a new guidelines, which is there was a gap of 8 years from the previous guideline published in 2015. Sorry, and I will tell you why we need to diagnose the disease early. And there's some suggested diagnostic algorithm from the guidelines and what are the available treatment options. All right. So now, in order to, let me just start the pointer. All right. In order to know what pulmonary hypertension is, I need to bring you back to the memory lane to go back to medical school. Even though this is a very simple overview of our circulatory system, but I think it's very important to know the idea of what and where went wrong. Okay, now what you can see here, just let me, okay, I hope you can see my laser pointer here. So essentially, if you remember, our body consists of two important circulations. One will be your pulmonary circulation, and then the other one will be systemic circulations. So in terms of pulmonary circulations, so you probably start from your right side of the heart, on right atrium, right ventricle, send the blood to your main pulmonary artery here, all right, and then goes to your lungs for exchange of oxygen, okay, as you remember. And then going through this capillary bed here before going back to your pulmonary venous system, going back to your left side of the heart. So this completes the so-called pulmonary circulations. And from left heart to the rest of the body is a systemic circulations. So now, as the name suggests, pulmonary arterial hypertension means it's a problem in this system. It has got nothing to do with your systemic circulations. Therefore, your blood pressure that you check using your hand cuff, your BP cuff, is checking the blood pressure over here. You can't actually check the pressure in your pulmonary circulation. So you need an invasive procedure, or you can use your echo to look for any signs to suggest that patient could be having a pulmonary hypertension here. So therefore, the essence is a high blood pressure of this part of the system. Okay, follow my pointer, which is a pulmonary artery here. All right, have a blood pressure of more than 20 mmHg, which I'll touch on that even more. All right, so now you know where went wrong. And then now I bring your attention to the clinical classification. There are a few different types of classification. The clinical classification of pH essentially is telling you what can cause pulmonary hypertension. All right, so now what you see here is the latest updated guidelines, 2022 classification. So the highlighted red color ones are those being reworded or considered a new term, some of them. So you don't have to pay attention to whether it's a red or black. For those who are interested, you may find the differences, but for those who are not familiar with pulmonary hypertension, you can just see as an overall. So now there are 5 different classification, 5 groups of pulmonary hypertension based on WHO classification. So group 1, which is a so-called biggest group because it consists of 6 different subgroup of causes of pulmonary arterial hypertension. If you look at word here, arterial, all right, as I mentioned just now, you have this arterial system coming from the right side of the heart to the lungs. And then you have this venous system where the blood coming back from your lungs back to your left heart. So that's a venous system. So as the name suggests, this is part of the system that get into trouble, which is pulmonary arterial hypertension. I know some people will use pH and PAH interchangeably, but to be more exact, pH is an umbrella term for all pulmonary hypertension, whether it's a venous system pulmonary hypertension or the arterial system. Okay, it's a kind of umbrella term. When you break it down further, PAH itself it means that actually more specific diseases, which is what I listed here. All right, so out of these 6 different subcategories, the most common one in this group is actually idiopathic PAH, meaning you don't know the cause. All right, after you have ruled out everything else, you can't find a cause, it's idiopathic PAH. But there's one more, we call it associated PAH here, which is gaining a lot of traction here because of this connective tissue disease related PAH. I think a lot of our rheumatologists now are kind of looking into, kind of looking into this disease more. So I think the connective tissue disease related pulmonary hypertension, or we will label the patient as APAP, which is an associated PAH, then you say secondary to connective tissue disease related. All right, and then the group 2 here, you can see, is PH associated with left heart disease. Last time it was worded as something like a secondary left heart disease, but now they want to call it more, better term. They call it associated with left heart disease. So in fact, as the whole PH thing, all right, the most common cause of PH, not PAH, the most common cause of PH as a whole is actually group 2. All right, because as you know, a lot of people with congestive heart failure, if you do echo, you will find pulmonary hypertension. So therefore, as you know, that cardiac disease is very common. So therefore, group 2 naturally is the biggest group of pulmonary hypertension. But this will leave it to the cardiologist to deal with, all right? And treatment is completely different. So for group 3 is the group pulmonary, they call it PH, pulmonary hypertension due to lung diseases. So it can be many things, can obstructive, restrictive lung disease. In the previous guidelines, they put a specific term rather than a general term. Now they reworded. Last time we called it COPD related PH. I call it, when restrictive, they call interstitial lung disease related PH. But now they're more general. Any obstructive lung diseases, any restrictive lung diseases can lead to PH. And but one important point that if you notice, the previously the obstructive sleep apnea was one of the possible cause of group 3 PH, but now they have seen remove it from group 3 pulmonary hypertension, because the multiple study has shown that if the patient only have isolated OSA without any other cause of say daytime hypoxemia, these are less likely or even unlikely can cause group 3 pulmonary hypertension. And then group 4 is another quite a rare disease, which is, many people get a pulmonary embolism, but not everyone will proceed and become a chronic thromboembolic disease. So when a patient that was when the patient had a pulmonary embolism before, and when they do echo, we found to have PH, then after 3 months of adequate treatment and patient remain elevated pressure in the lungs, then we will call it PH secondary to chronic thromboembolic disease. All right, this is group 4. But today we're not going to touch on that because it's a huge topic on its own. And then group 5 is the one that is so-called unknown, multifactorial, many reasons, and it can be different systemic diseases. Some of them are quite poorly understood, that how it actually leads to PH. So such as your chronic renal failure and many other diseases, which it's still a lot of research being ongoing to try to differentiate this group. So other than hemodynamic classification of pH, there's one more important classification, is so-called hemodynamic definition of pH. So if you see the far left-hand side here, you can follow my laser pointer here. We can divide them into pre-capillary, post-capillary, and combined pre- and post-capillary pH. This is purely, you can only differentiate these groups by doing a right heart catheterization, for which I will touch on later on. So now the bottom line here, I know that's a very busy slide. The bottom line here, first of all, the focus of this column here, because this is the latest guideline, 2022 definition, and then on the left-hand side here, 2015, there's slight changes in terms of the pressure, all right, based on many evidence. They have kind of reduced the pressure from previously more than 25 millimeter mercury to be called a pH, but now they have reduced it to just 20. All right, because there's multiple morbidity, mortality study, they found that anything more than 20 is enough to cause significant changes. So now, if you cannot remember all this number, which you don't have to, you just have to remember this one number here, which is a mean, MPAT's mean pulmonary arterial pressure. All right, measured from right heart cath, more than 20 millimeter mercury is enough to label a patient having a pH. Okay, an umbrella term, pH. But if you want to differentiate them into, this diagram is shown, whether it's a pre-capillary, meaning before this, or post-capillary, which is likely to be due to the left heart because it's congestion from this part, which all leads to congestions of capillary, then overflow back to your pulmonary arterial system. So you need the right heart cath to get the rest of the number, all right, which I'll touch on when I talk about this right heart cath briefly. All right, so this is how to differentiate using hemodynamic. So now, how common it is to have PAH? Some of you may say, oh, in my practice for so many years, I have never seen one. Well, it could be true because it is a rare disease. Well, it's a progressive disease, even though it's rare. The incidence rate is about only 6 per million population in the world, and the prevalence rate is about close to about 50 cases per million. Unfortunately, Malaysia do not have our own registry. This is something that me and IJN is in collaboration trying to find out with the actual number we have in Malaysia. We don't really have a good registry to say how many we have. And it affects everyone and all ages. However, there's a 2-to-1 more common in female patients in the ratio of 2-to-1. And the median survival of the patient is only 2.8 years for those who left untreated. And mind you, these are the data getting from group 1, as I mentioned, because this is the group that is most studied and the most evidence that is available nowadays, which is this one, group 1. And then the symptoms obviously will decrease the quality of life, and then they result in frequent hospitalizations. And as I mentioned before, of all the group 1 diseases, the idiopathic is the most common, which constitute about 50% of all cases, followed by your connective tissue-related PAH comes next. And then the last two will be your congenital heart disease and portal hypertension. If you notice that, these are the data coming from European or Western countries. So in Malaysia, somehow I noticed that, at least at my centers, I'm seeing a huge number of congenital heart disease leading to PH, rather than idiopathic and the CTD. Maybe I'm capturing a different cohort of patients. I'm not sure about that part, but we need to come up with our own Malaysian data to see which one is more common or prevalence in Malaysia. So I did mention about the median survival, right? The purpose of this talk is to raise awareness, to tell you how bad this disease can be, even though it's rare, but it can be very bad. If you look at this chart comparing the median survival with the cancer patients. So what I mentioned here, if a patient left untreated, the median survival is only less than 3 years for those who presented to you when they were in the functional class 3. Essentially, WHO functional class 1, 2, 3, 4 is the same definition, almost the same definition in as your NYHA classification. You can safely assume they are the same. So meaning the pulmonary hypertension presented to you with functional class 3 and left untreated, the median survival is only 2.8 years. But essentially, it means that it's worse than many of your like colon cancer, rectal cancer, and so on. By dropping their functional class, meaning you give treatment, hopefully the functional class will drop from 3 to 2. We can see how much it improved in terms of a 5-year survival. Therefore, we need to capture them and give them treatment so that survival will improve tremendously. So now, I've mentioned multiple times, PH is a progressive disease. Whether you give them treatment or you don't give them treatment, they will progress. Just like if you give them treatment, they will improve. Some of them will reverse something for a period of time before they actually progress again. All right, unfortunately, it's progressive disease. But my point is, if you look at here, just follow my pointer here. We will try to capture them at the very beginning, which is a functional class 1. Essentially, they are asymptomatic, except the exertional dyspnea, because you can see the CO is cardiac output. Cardiac output at this time is relatively rather stable and normal, but when you can see this PAP means pulmonary arterial pressure is start going up already, and the pulmonary vascular resistance also going up, despite the fact that the cardiac output is still normal. Therefore, the patient is quite asymptomatic. So when they progress to become functional class 2 or 3, that's the moment when you see the cardiac output start dropping. Before, if you capture even later at the functional class 4, meaning they're already at a decompensated state, you can see the right ventricular dysfunction already kicked in. And you do not want to capture them at this time because likely there's already have permanent damage on your right side of the heart. If you're not convinced enough, look at this chart. Why do we need to catch them early, identify them early? Simply because if you look at this, the Kaplan-Meier curve here, the left-hand side, just focus on the left-hand side first. These are the patient you capture a different stage, So if you capture them at when they are NYHA class 1 or 2 versus NYHA class 3 and 4, you can see if you give treatment at the same time for these two group of patients, even you start treatment at the same time, just because I present late, you can see they diverge so much. These 3 and 4 group, they do so much more worse than those presented at early phase. All right, even you give treatment to these both group of patients. If you further dissect them into 1, 2, and 3 and 4, you can see even between 3 and 4, you just catch them at 3, NYHA class 3. It's already helped them a lot, and you can pick them up early. You can even you can see they kind of get more lifetime than the rest of the group. All right, even if you start treatment at the same time. So I hope I've convinced you enough that to pick them up early. But exactly how do we do that? Because the most important problem, all right, the problem that we are facing when we're diagnosing a PH patient is simply because if you look at this diagram, it shows you all the common symptoms that we have for pulmonary hypertension. Sorry for the background noise here, sorry. So because you can see here, the symptoms of pulmonary hypertension is quite non-specific. You have fatigue, you have lightheadedness, you have shortness of breath, you have palpitation. So these are the symptoms you will find in say your chronic lung disease or even all the heart diseases. And most common symptoms is actually shortness of breath, which is can happen in many diseases. So you can't really pinpoint whether this is due to PH or not. So that's the hurdle. So now the latest guideline 2022, they focus focus a lot on early diagnosis, simply because if you look at this here, follow my pointer here, the average time for the Western countries, even for the Western country, the average time for them to reach a diagnosis from symptoms presentation is actually more than 2 years, even in the so-called the developed world, you know, and what more in our part of the world. I think our delay is so much more than that. So because of these, when they see the patients, they're already more severe and become more difficult to treat. So therefore, the current guidelines emphasize a lot on catch them early. So now, what are one of the most earliest symptoms? I would suggest look hard for unexplained dyspnea on exertion. All right, because these are kind of the symptoms you will hear from your patients. The rest is very mild. You don't hear any other symptoms other than they will tell you, oh, this patient is just coming to you with unexplained shortness of breath. So here you can see fatigue and rapid exhaustions. Here are the two top symptoms that you shouldn't miss. If you've done every test, you do everything, you can't find a reason why, then don't stop it there, because these are the common symptoms. All right, you don't want to wait until it becomes late. You give you all these so-called exertional chest pain, and this is usually due to the compression of the pulmonary artery, because they enlarge so huge, they compress on the coronary artery, causes exertional chest pain. When compressed on the recurrent nerve, it leads to this hoarseness of voice. All right, these are all the late symptoms, that we do not want to wait until we see this. So now these are some suggested diagnostic algorithm. All right, so they kind of split them into 3 different steps. Okay, step 1, importantly, very important, is the comprehensive history, meaning you need to have a high index of suspicions. And then, until now, history taking, physical examination is important for all diseases. I hope you agree with me. So history is the one that will tell you something is not right. And physical examination, while you may be able to pick up some, loud P2, some, leg swellings and all that, but usually these are quite late. You don't want to pick them up when they have a leg swelling, they have SIDs and all the right heart failure sign. If at your center, you will have this pro-BNP or BNP, do send them. It will tell you it will actually tell you a lot about your patients. And then if you don't have on any of these, I'm sure you will have ECG. Even though it's non-specific, probably it's going to tell you some RVH, LVH, this kind of sign on the ECG, but it's better than none. You can try to pick up some minor signs. So if you have enough suspicion to make up your case, you can proceed to step 2, to do some simple investigation first. So here, number 1 here is a non-invasive lung function test, such as, for example, your spirometry or full lung function test. These are the or your gas exchanges. These are the tests that you can do to kind of pinpoint or rule out other causes of the unexplained shortness of breath. But if you look at the patients, you think that cardiac disease is more likely, why don't you proceed with non-invasive cardiac tests? I think echo nowadays is quite widely available across many hospitals in Malaysia. So you can look and send your patient for an echo. And with an echo, trust me, you will get a lot of information from the echo on the right hand. So I will touch on quite a fair bit later on about echo and what do you look for, all right, at your center. So after you've done this, that step 2, meaning you try to investigate at your center first, then you think that, there's whether it's low probability, intermediate probability, or high probability of having a pH from echo, from history. All right, that's a moment that you're thinking about referring your patients to a pH center. So in that case, I'll touch on about intermediate and high probability. So because echo, after you have classified them, you can classify a patient into low, intermediate, and high, as I mentioned. So if after echo, you found a patient in the intermediate and high probability, don't think too much, just refer to us. All right, if you have a patient who after done echo is still at a low probability, then you need to look for other risk factors. For example, whether the patient have any concomitant connective tissue disease, HIV, the schistosomiasis, or even congenital heart disease. Then if they have, even though echo shows quite okay, you might want to repeat echo in 3 to 6 months later to see if there's anything changed. All right. Okay. At our center, what we do is we will proceed with invasive tests. Usually, I'll refer my patients to our friendly cardiologist to go ahead with a right heart catheterization. And furthermore, we'll further refer to establish which group of pulmonary hypertension they are. So now, this is the diagnostic algorithm. I know it's a busy slide. You don't have to look at everything. So it is from suspicion to diagnosis. So I just want to draw attention to the very top here. All right. So now the latest guideline here, as you mentioned, they involve the general practitioner, the GP, the primary care, because we know majority of the time they are the gatekeeper. If they miss this, we missed it. So that's why they included what the GP can do. Just a history, examination, ECG that I mentioned before. If you suspect something else, then proceed with do whatever test you can do, even the chest X-ray, ECG, and echo. And after you have done the basic test, the following slide I will talk about the probability, then you refer them. Okay, we don't expect, because it's a difficult disease, we don't expect the GP or the primary care to be able to diagnose a pH, but at least you need to have a high index of suspicion. So now, this is actually a new echo, what I call it, flowchart, all right? It looks very busy. To me, it's quite complicated. So I don't really like this, but I put it here for you to tell you that there's a new flowchart. I prefer I show you this one. So this is actually published about 8 years ago, but the numbers are the same, meaning whatever has been written here on this flowchart is essentially the same as the chart that I showed you just now, but just that so much more simplified. All right. So what we look at on the echo is not about left ventricular ejection fraction. It's not about what the thickness of this wall, thickness of that wall. No, the most important number here you're going to look at is your TR jet velocity, tricuspid valve regurgitation velocity. And I'll tell you why we only look at this one. All right. So you see a TR jet velocity here. Usually the report, it won't put on the top of the report. You'll be at the bottom there where they put all the numbers. You just have to use a magnifying glass and look for this TR jet velocity. All right, they will tell you over there. So look for this number. Some report they will use centimeters, some report use meter. So I use meter here because internationally they use meter per second. So if the report says the number is less than 2.8 or equal to 2.8, or you say, oh, I can't measure, then you follow this flow. So if it is not measurable and less than 2.8, you need extra echo sign, echo pH sign. So in this guideline, it says you need to have extra 2 echo pH sign in order to continue to classify the patient. So what are these so-called echo pH sign? Following chart I show you here. So now you can see here. So essentially, what I show here is 2 echo categories, right? Okay, what are these 2 categories? So here on this table, we can see A, B, and C. All right. So essentially, there are 3 different categories of echo pH sign that we look at. So the category A here is looking at the ventricles. Trust me, you won't be able to find all the wordings you want to find in the standard echo. But this is the second point here. The flattening of the interventricular septums is almost always, if present, your technician will always put it there. Okay, look hard for this. All right. So what exactly is a flattening of interventricular septum? All right. I'm no expert in echo, but these are the basic things that we have to know. So meaning the normal echo on the left-hand side here, you can see my pointer here. So this is your left ventricle. All right. Left ventricle, as you know, is more muscular and round in a normal situation. And the right RV, the right ventricle here is usually quite flappy, small here. All right. So it's just different pressure, isn't it? But in case of pH, you can see your left ventricle here, my pointer here, is being squashed to one side because your right ventricle is already enlarged and high pressure and push the interventricular septum, like over here, become flat. It's supposed to be rounded like this, it becomes flat. Or some people label this as D shape of your left ventricle. So this is one important sign, meaning your left heart is fine, but the right heart is not. Okay. So with this, you can say, oh, patient have 1 category of pH sign on the echo. The second category you can look at is your pulmonary artery. And out of these 3 different things you can look at for pulmonary artery, majority of the time you only find 1, which is a pulmonary artery diameters. And they usually mention if it is abnormal. If normal, I hardly see them report in their echo reports. So if the pulmonary artery diameter is more than 25 mm, then yes, they score another category. The other 2 is I hardly see them write down on the report. But if you're interested, you can try to look hard for that. And the third category C here usually is available, okay, which is your inferior vena cava, the IVC size and the collapsibility. Okay, I believe quite a number of echo reports will put this. If you still don't put this, look for your right atrial area. And again, right atrial area, if you look at the wording part, usually they won't say how much. You have to go down below at your echo report and look for the numbers. All the numbers will be there, and look for the RA and centimeter square. So that would be your right atrial area. If it's more than 12 centimeters square, so then they score another category. So you need two, ABC, you need two category to be fit into this so-called flowchart. Okay, so you have less than 2.8, you have two category, then yes, it's intermediate. If no, then it's low risk. Low risk doesn't mean they can discharge a patient. If the patient is symptomatic, you might want to repeat it later on, like 3 to 6 months later. So if between 2.9 to 3.4 meter per second, even without this category of a pH sign, it's still intermediate. If it is more than 2, it becomes high probability of pH. But if the velocity already more than 3.4, you don't need any other echo sign. It's enough to say that patient having a high probability of pH. So what does it actually mean? So if you have a patient coming to you with intermediate and high probability of pH, okay, in the right clinical situation, meaning the symptoms and all that, please refer to your nearest pH center. All right. I'll touch on pH center as well at the end of my talk. All right. So if low, as I mentioned before, if they can risk factor, symptoms is there, history of CTD, history of PE, then don't just stop it there. You can always repeat it. When it's in doubt, just refer to the nearest tertiary center. We can work it out from there as well. All right. I hope I made this clear. All right. I think this is very important to how do you look at your echo reports. So now, as I mentioned before, why do we use TR jet velocity but not any other thing? Because a lot of echo report actually will straightaway give you the PASP, which is a pulmonary arterial systolic pressure. They calculate it for you already, and they actually derive it from your TR jet velocity as well. But because in order to calculate PASP from TR jet velocity involve multiple calculation and a lot of assumption. The more assumption they make, the more calculation they make, the more likely that the final numbers is inaccurate. And this is also because I want to show you this one, which is sensitivity and specificity of transthoracic echo to diagnose pH. If you look at these three different studies, you can see the sensitivity ranging from 0.79 to 1. The specificity ranging from 0.60 to 0.98. So meaning it's a huge range. It's all operator dependent, depending on the centers, depending on definition, depending on how the person do it. So there's a lot of a huge range of these, uncertainties. Just imagine if that one person calculate using 2-3 assumption to give you this pressure. I think I would rather take the one that at the very beginning, which is a TR jet velocity, which is a directly measured numbers. So therefore, the guideline also mentioned just use your TR jet velocity as the number that you look at. Okay, not the PASP, because sometimes it just confuse you even more. Right. After echo, what do we do next? So now, obviously, we don't expect those centers who do not have the facility to do all these tests. But if you have, so why not proceed with the we call it routine blood test. So routine blood test means your biochemistry, look for renal function, liver function. As you know, renal failure, liver failure both can also lead to pulmonary hypertension in a different way. And hematology, hematological diseases can also leads to pulmonary hypertension. Thyroid function is because a lot of pulmonary hypertension patients will have concomitant thyroid dysfunction. That's why we also want to look for that, and so also serve as a baseline. And NT-proBNP to start there is if you have at your center, because many centers do not actually have that. If a patient presents to you with some connective tissue disease sign, why don't you send for the basic test to rule out connective tissue disease? But at my centers, I always send a basic CTD screening, because I do not want to miss a CTD related pH, because the treatment will be completely different as well. And the meta study has shown that some patients with pH with underlying connective tissue disease, they may not actually manifest the CTD yet. They will present as your pH first, then they will manifest your CTD symptoms. So that's why it's good to screen them first. If you have something that's positive, but you can't diagnose yet, you can refer to your friendly rheumatologist to look into that in further. And if patients presented meeting the criteria for chronic thromboembolic pulmonary hypertension, or CTEPH, then you might want to send thrombophilia screening. Because sometimes I receive referrals when patient already on a long-term anticoagulant, then I can't actually screen them for this thrombophilia screening, because again, if you have thrombophilia, if this is an antiphospholipid syndrome, the treatment may be slightly different in terms of anticoagulant as well. So we need to know that if possible. So now here comes to right heart catheterization. Of course, I'm not cardiologist. I refer my case to cardiologists to do it, but it's good to have an idea of how do they do it and what are the numbers they will look for. So now right heart catheterization essentially is inserting this Swan-Ganz catheter, all right, into your central venous system, all right? So it's actually different from the normal cardioangiogram, which is going through your arterial system, because this Swan-Ganz catheter will be inserted in the venous system because you want to insert it all the way to your right side of the heart, right, the venous system, to get the pressure. And obviously it is done in this cath lab, all right? So we can go into their territory, yeah? So now, what are the numbers we look for? So just follow my laser pointer here. All right. So depending on whether you catheterize the patient through your internal jugular vein or your brachial or femoral vein, so you come for either for your superior vena cava or inferior vena cava. So go into your first right atrium. So these are the first number you will get. So right atrial pressure normal is 2 to 6. All right. After they measure the right atrium, you'll push the catheter down further to your right ventricle. Okay, you'll get a pressure about 20 to 30 in normal situations. After they measured here, you catheterize further. This maneuver, some cardiologists say may be slightly more difficult, but most say okay. Number they were looking for, okay, which is a pulmonary artery pressure. Okay, so it's between 20 to 30. We're gonna get a mean pulmonary arterial pressure, and then after you get the pulmonary arterial pressure, the operator will further catheterize this catheter all the way till you can hear me, right? Yeah, you can say internet connection not stable. But anyway, so you can catheterize and push all the way to the end of the capillary, and you wedge it there. When you wedge it there, you get the number of the capillary wedge pressure. So if you look at this here, the catheter at the end of the capillary, so essentially the pressure here you wedge there, you are actually measuring the pressure in the capillary bed and the post-capillary pressure. So sometimes we call it a surrogate pressure of your left atrial pressure. So essentially we are trying to look at this number to see if it is high. So what does it mean by high? Okay, so if sometimes you use PAWP, yeah, it's a pulmonary arterial wedge pressure or capillary wedge pressure. So it's interchangeably PAWP, PCWP. So if less than 15, okay, if less than 15, essentially it means your left heart pressure is normal. If you have the pressure more than 15, it essentially means your left heart is actually overloaded. When you have overloaded on the left side of the heart, meaning the patient likely to be having a post-capillary pH leading to pulmonary hypertension. And in that case, left heart disease being the most common cause of PH, then you might want to refer the patient to a cardiologist instead to rule out if the patient having congestive heart failure. All right, but by then, the person who's doing this procedure, since it's a cardiologist, I'm sure they will look into that as well. And then this PVR here, okay, which is a pulmonary vascular resistance, is a calculated numbers by the computer. All right, so the person who will report these numbers. The measured one is just this pressure, not the various vascular resistance. All right, I hope this is not too hard. So now you have diagnosed this pulmonary hypertension. All right. So, I mean, this is just an overview of treatment options. You don't really have to know exactly, but it's good to know what we can do. All right. Diagnosing pulmonary hypertension is not the end of the road. There are increasingly more and more treatment options available, and a lot of research is ongoing to help this group of patients. So it's good to know what we can do when you refer. So now these are the three important signaling pathways. So 3 pathways we can target to treat our PH patient. So namely, the first one is an endothelin pathway. So we call it in short ERA, which is endothelin, this pointer here, endothelin receptors antagonist. So essentially you're blocking the endothelin receptor A and B, or preventing vasoconstriction. All right. So they have 2 different groups, selective and dual binding, ERA, bosentan, macitentan, and ambrisentan. They are all extremely expensive medication. And the second pathway is commonly prescribed in many centers, not even in PH center, is your nitric oxide pathway, because the common medication, I'm sure all of you will know, is your PDE5 inhibitors, your sildenafil or Viagra. All right, it's used to treat pulmonary arterial hypertension here. So the other one, more expensive one with tadalafil, they serve the same purpose, but sildenafil now is a generic drug, so a lot more cheaper. And but it's TDS dosing, while tadalafil is actually once a day dosing, a lot easier. So the other one in this nitric oxide pathway is actually a cyclic soluble granulic cyclase stimulator. So essentially, this is a what actually stimulate this pathway to increase the production of nitric oxide. While the PDE5 inhibitors is kind of a prevent or stop the breakdowns of nitric oxide. So they kind of a synergistic effect. But however, because of this effect, one's increasing the production, one preventing from breakdown. So these two medications are contraindicated. You cannot give two of them together. Okay, it's either one because it can cause very significant hypotension. All right. So now the third pathway is the prostacyclin pathway. As you know, prostacyclin is a very strong vasodilator. All right, we have both these prostacyclin analogs and those we call it non-prostanoid this agonist. So meaning essentially only binds to the receptors. All right. So one of the available medication here is oral selexipag. Okay, because majority of them is either inhale or intravenous. So it's actually quite troublesome to administer. But selexipag is one of the only one that is available in Malaysia. With proven clinical evidence, as well as it is effective and is orally prescribed medication. So obviously, prostacyclin improves the vasodilatation and prevent proliferation. All right. So these are that's kind of overview. So how do we choose which one to give? So now, before we can decide what do we give and how do we choose, we need to know about risk stratification, because the choice, I mean, the medication choices is kind of based on the risk stratification of the patient, meaning whether they are low risk patient, intermediate risk patient, or they are high risk patient. So what does it mean by all these low risk, intermediate risk, or high risk patient? So high risk mean if you have these features, all right, meaning they are high risk of more than 20% of what? Of 1 year mortality. This is very bad. Okay, the latest guideline increased from 10% to become 20%. Right, last time it used to be only 10%, but now 20%. For low risk patient, meaning they have a 5% chance of 1 year mortality. So this is what we call risk stratification on pH. So based on what risk they are, we can decide what is the initial medication you would like to choose. Okay, so it looks like a very busy slide. Don't worry, I will just categorize it for you. Because on this risk stratification, essentially there are three big categories of parameters or variables we look at. So the first category is, we call it the clinical features. So whether the disease is progressing rapidly or slowly, or whether the patient has syncopal attack before, or and also the functional class of the patient. All right, and then the second category is so-called the exercise exertion, the exercise tolerance of the patient. So the simplest one to do is a 6-minute walk distance. All right, so obviously the more the better. And if your patient can perform CPATs, cardiopulmonary exercise testing, then you can also ask them to go and get this test done. But it's hardly been done in many centers because of I think availability. And also, second reason is, unfortunately, many of our patients are actually too breathless to actually get a meaningful number from CPAT. That's why majority of the time we only do 6-minute walk distance. And with that, also they have a difficulty of doing it as well. And the third category will be the so-called investigations and blood tests and scans and all that. So such as the one commonly I do is your NT-proBNP. Simple test, blood test, it can get the result. Then you can put them into whether it's low, intermediate, or high risk category in this case. So I think it depends on what you have at your centers. Just pick what you have, all right? Sometimes it's not easy to have everything. For example, cardiac MRI. IGN can do it, but in Sedang, even though we have the machine, but because of long queue, I hardly can get any of my patients to do cardiac MRI. And hemodynamics are the one from your right heart catheterization, all right, and categorize them. So after we have put them into this so-called category, risk category. So this deal, okay, again, a busy slide, but just focus on this rate. Focus on what I have highlighted here. So once you have already categorized them, then you can follow this flow chart. Okay, the first important flow you have to see is whether the patient have any cardiopulmonary comorbidities, such as if patient have any advanced COPD, any uncontrolled asthma, or any heart diseases such as your congestive heart failure or IHD. So if they do not have any of these comorbidities, you follow left-hand side flow. If they do, then follow the right-hand side here. Okay, the left-hand side here is the one that look at the risk stratification. The risk I show you just now. If it's low or intermediate risk, you can start with ERA, which is bosentan, macitentan, and macitentan, plus your PDE5, which is sildenafil, tadalafil. Well, this is recommended by the guidelines. However, because of the cost, we hardly can do this upfront combination therapy. Majority of the time, we can only start on either one, which is usually sildenafil, which is cheapest now. And then by 3 to 6 months later, if patient is still not controlled, which is most of the time, then we quickly get funding to add on your ERA. So if you have a patient came into you with already a high risk, you, according to guideline, you should start the patient on intravenous prostacyclin, which is still not available in Malaysia, not even in IGN, because it involves a huge service. Okay, so which we'll not touch on. So even patient coming with high risk at my center in Serdang, we still try to maximize oral therapy rather than the recommended intravenous or subcutaneous prostacyclin analogs, PCA. So for those with some kind of comorbidities, heart failure, advanced lung diseases, you can try with oral monotherapy first, which is unfortunately is what we are doing for all. About this pulmonary hypertension center. All right, this is actually recommended in the current 2022 guidelines. So how do you call yourself a pulmonary hypertension referral centers? So it is suggested that you have certain core members of MDT and the extended members of MDT. So fortunately enough, in Serdang Hospital, we have almost everyone. For cardiologists, me with the right heart cath, thoracic surgeon, we have quite a number here, and we are the ECMO capable hospital. And nurses, this is the biggest issue. I think I do have one nurse, but only spending less than 10% of the time on PH. And we do have interventional radiologists and cardiologists because as you know, for CTEPH, the gold standard actually is to do a pulmonary angiography to look for the sign and features of CTEPH, which is difficult to do in Malaysia because hardly anyone will give you the complementary pulmonary angiography on table. And then social worker, I have a very good one, and study nurse, if you have any clinical trial ongoing. Case manager probably is myself, and the data manager is also myself. So other extended one, I think I'll draw attention to, I think they put the rheumatologist at a very low and the thoracic radiologist at very low. I think they go by the alphabetical order, but I think they should be at the top of the list because now we are collaborating a lot with rheumatologists for this associated PAH due to connective tissue disease. This group of patients are relatively young and they have a lot of treatment options. You do it properly, correctly, their life expectancy is so much better than other group of PH actually. So I think that brings me to my take-home messages here. I hope I'm still keeping on time. So I hope I have convinced you enough that pulmonary hypertension is a very serious disease and now has a lot of treatment options, and it can be given in the public hospital, even though it's expensive. How expensive it is, you're looking at least about 70 to 80,000 ringgit per year per patient. Or that's how expensive it can be. And high index of suspicions for those unexperienced shortness of breath is important. Don't just leave it. You can always catch them early. I've seen some live on for 10 years or 15 years with PH without any issues. So it can live very long if you catch them early. As I mentioned, early referrals is vital, and echo is a super valuable tool as a first step investigation at many centers. Okay, something's wrong, don't hesitate to call for help. And right heart cath remains the gold standard. I need to stress this point. Many people actually will ask me these questions. Can we diagnose PH without a right heart cath? My simple answer is no. Just like this has been raised in international scenario as well, and many of the experts say no, simply because PH is a very serious disease. with short life expectancy, and treatment is extremely expensive. You don't want to embark on this journey when you can't even confirm whether they actually have it. Right? Just like cancer, you can't be saying, oh, this patient suspected to have cancer and you start treatment. You can't do that, right? So the same goes to your pH. You need right heart cath, which will give you the pressure, exactly the number you need. So that's the number you need before you start talking to your patients and getting the money to start medications. Early treatment improves prognosis and quality of life. We knew it from multiple clinical trials, and this is the way to go. All right. And with that, I thank you for your attention, and I would be happy to take any questions.
Okay, thanks, Lee, for the excellent talk. I thoroughly enjoyed it. I think we have about 10 more minutes for questions. So
sorry, I was short a bit.
I think you probably answered the question on the Q&A with your conclusion slide. It's from Dr. Azmat. The question is, can I ask if transthoracic echo has proven pulmonary hypertension? Is it necessary to do a right heart catheterization? Will it change the management? Anything you want to add?
Yeah, I think I expected these questions because this question has been asked almost every time you have a PH masterclass or PH talk, so I think the answer I've mentioned before, no, because as I mentioned, because it's a poor prognosis, you can't be telling your patients that you have 3 to 5 years to live, but you can't even confirm whether the echo is correct. I understand that echo is quite accurate nowadays, but still it's an estimate. Because echo is just a probe putting in front of the chest, and how they estimate is looking at the flow and measuring the flow by the graph, and then they estimate the pressure for you. So I don't think we should be doing that, in this is such a terrible disease. Yeah.
Okay, thank you. I think there are no other questions. Could I just ask you if you have a very poor window for TR velocity on your echo, but a strong suspicion for pulmonary hypertension, what would your approach be?
Yeah, a very good question. You see, a lot of times you always see this, it's not unmeasurable. If you said non-measurable means it's could be normal, all right? But if you say it's poor window for measuring TRG velocity, then it's kind of I would say that kind of a flag, meaning they saw something, but they don't want to commit what they saw. So in that kind of cases, either if the patient is relatively well, not too symptomatic, I will repeat the echo. And sometimes what I do, especially when I receive cases from other centers, I will do it in Sedang because it's operator dependent. And I must say that I think our Sedang echo technician are pretty good. So they will actually comment, even though there's a little bit thing they see, they will comment and ask you whether to repeat it or not. So repeating it is one thing, but if patient is very symptomatic and you have really high index suspicions, I occasionally will speak to my cardiologist straight away. Of course, I'll support myself with extra tests, for example, anti-proBNP is elevated, and also if possible, if patient can still perform your CPAT, then cardiopulmonary exercise testing, you go ahead because you can get your supportive thing. Because now our cardiologists are actually quite aware of this. They will actually refer the case to us to do a CPAT to support the diagnosis of PH before they proceed to do right cath, because the cath lab time is too tight. I think Sedang has been in a new spot for a wrong reason for a couple of weeks ago. Yeah. He's trying to kind of balance it and the time and all that. Yeah, this is what I would do. Yeah.
Okay, thanks. I think there are no outstanding questions, but I'd be quite grateful if you could just briefly inform us about treatment accessibility these days.
Yeah, very good. So very good question instead. I think this is very important to be, because a lot of people, they don't refer because they know that it's hard to start treatment. So what I do here is I believe in try your best to get the funding. I'm lucky that for now, most of the patients that refer to me, I somehow can get the funding to start something up until now. I have not been rejected by anyone yet for my applications, but of course I have a lot of different sources of funding. From if they are Muslim, I go through a Zakat by Tumal. They're quite supportive. I have quite a lot of approvals. If they are from JBA, no issue at all. They will start. They will approve it for sure. If it is state government level, they will approve as well. And last but not least, our hospital has this social, we call it medical social welfare, and we apply through medical social welfare to fund the patient as well. So these are the options you can get. And what we are trying to do now is to get more funding to use the so-called the KKM or hospital budget. And this is going quite well now. And because one of the medications is going to be listed in Blue Book soon, I hope Blue Book, then it will be a lot easier easier to be accessed by our patients. So there are a lot of funding options. It may be difficult. You may wait for up to like 6 months, but eventually you will be able to get it. Yeah. So do not hesitate to refer them. Yeah.
Sure. Is there any effort to get a special PH fund or anything like that?
Yeah, the Ramesh. Well, I have been bringing this up with my boss here, and the reassurance is there. But you know, there's a lot of red tape and all that at the higher level, which is beyond our control and the boss's control. I am still trying to collaborate with IGN because now IGN has been sending a lot of patients to me. So and they have some funding for that as well. So I'm trying to see if we can have some kind of collaboration from IGN and KKM as well, but it won't be too easy because it's a two different institution and all that. Yeah, but this is what I'm looking at in the near future. Funding is a huge issue for PH. Huge issue. Yeah.
Okay. So I think it's 3:56. I think I thank you, Dr. Lee, and we all do for sharing your expertise in this area with all of us. I wish you all the best in getting more funds for your patients. I think there's one more last question. Probably you can just give a brief answer. It's from Dr. Nabila. How about lung transplant in idiopathic PAH?
Yeah, it's a very good question actually. I didn't touch on lung transplant, but in fact, yes, idiopathic, not just idiopathic pulmonary hypertension, in all type of pulmonary hypertension, if not all, most of them, that you can actually refer for lung transplant when they're already at the high risk group and they started all the treatment, oral therapy, intravenous therapy, but they're still not responding to you. I think that's the moment you should refer for lung transplant assessment. But whether the PLEASE program is going well, that I think is beyond what I can say here. And but I do have a very supportive colleagues in Sedang Hospital who are running the lung transplant program for the nation in Sedang Hospital. So I will just refer my patient for them to have a brief talk, about the program, and probably will list the patient for lung transplant when the next thing is available. Yeah, yes, absolutely. The answer will be yes. Lung transplant is an option for this group of patients, but I will wait relatively late before we refer them. Yeah, meaning not too late, but not too early. That's the sweet spot they have to pick. So that's why I refer to my transplant colleagues and let them assess that. Yeah,
sure. Okay. Thanks, Lee, once again. I think in view of time, I would like to pass it back to Dr. Koh and the organizers. Thank you.
Thank you, Dr. Kumaresh. Thank you.
Thanks, Dr. Kumaresh. Thank you so much, Dr. Lee, for the very insightful talk. And thank you to everyone in attendance. It was really fruitful for me, and I'm sure I speak on behalf of everyone else in attendance. I'm sure we have learned a lot as well. So with that, we would like to close the session for today.